Hi, everybody. Welcome back to another episode of ASAP Pathway Podcast. I'm your host today, Dr. Stacy. I have one of my dear, dear friends today, and I'm so excited to just be here with you all and have this conversation with everybody. And if you are part of this airway awareness, craniofacial respiratory complex movement, you know who Dr. Kevin Boyd is, and that's who I'm talking to today. Welcome, Kevin.
Thanks. I'm so thrilled to be interviewed by you. So let's rock and roll.
Okay, let's rock and roll. I mean, I love this man, and I'm just gonna tell you guys, literally, Kevin, you're the reason any of this is even happening. I came to you years ago with my own kids, and you're the reason, anyone listening to these podcasts, his name pops up all the time. I mean, the podcast that just was released this past week with Lou Shmura, we brought you up, Steve Carsonson. I mean, you are the reason so many dentists, orthodontists, pediatric dentists have taken up this mission, if you will, and press forward. They'll say Kevin Boyd, Kevin Boyd. It's because of Kevin Boyd. So the ripple effect, my friend, of what you're doing is huge. It's international. It's huge.
Thank you. That does my ego wonders. At the same time, I just I'm feel it's the movement's got to get stronger. Period. And it is. And
It
thanks to
is.
people like you and Tracy and Michelle.
For those of you, I want to read, this is by far not an exhaustive bio, but let me just tell you a little bit about Kevin Boyd, Dr. Boyd. And now I have to put my readers on because I am reading your bio here, but Kevin is a board certified pediatric dentist practicing in Chicago, Illinois. He's also an attending instructor in the pediatric dentistry residency training program at Lurie Children's Hospital, where he additionally serves as a dental consultant to the sleep medicine service. He also serves as a dental consultant to Lutheran General Hospital. He's a visiting scholar at the University of Pennsylvania's Museum of Anthropology, conducting research in anthropology and orthodontics. Prior to completing his DDS degree from Loyola University's Chicago College of Dental Surgery, that's a long word, in 1986, he obtained an advanced degree in human nutrition and dietetics, which is so interesting, which just makes your lecture so interesting too, Kevin, from Michigan State University. He completed his postgraduate residency training in pediatric dentistry at the University of Iowa due to its reputation for providing intensive clinical and didactic learning opportunities in the areas of early childhood orthodontics, dental facial orthopedics, and also early childhood behavior guidance management and child psychological and emotional development. Which is like, Kevin, I think that's also part of it too. You and I have talked about this. You have just such an angle with nutrition, diet, anthropology, why we are growing the way we are and developing the way we are, but also behavior management. That's a huge component to all of this, which I think is what gives you such when you speak, the different facets that you're bringing to this. In order for this movement to happen, you have to take all those things into consideration. So, I mean, you're my mentor. You're so many people's mentors. Who's yours? How did you even get going in this from,
Who was my man? Probably Clem Full, rest in peace. He was my clinical director at the University of Iowa, who was just so determined that we would get exposure to early dental-facial orthopedics. Early then meant, before age 8, which, I call a geriatric patient now. But it really wasn't. It was at odds with the head of orthodontics. Their clinic was right next to ours. And it was just, he just would go head to head with this guy, and no, your residents need to learn pediatric behavior guidance, and my residents need to learn growth and development. So he sort of made sure we took ortho classes with the orthodontic residents, and we learned growth and development from Sam Bachara, very legendary orthodontic academic. And I learned to bend wires with Andreessen, who's the guy who invented nickel titanium wire. So John Casco, maybe he's no longer with us either, but he wasn't for that, but still Clem Full was very persuasive in getting our curriculum, really enriched with the orthodontic standards. So that was first. And then I think Robert Corricini, who anthropologist, he wasn't a dentist. And, when I became aware of him, things kind of changed and put a new framework for me to study it with. And then, of course, Bill Hang and John Mew. John Mew got me access to the Roman skulls at the British Museum of Natural History. That same skulls he studied to develop his, what he calls orthotropics, correct or optimal growth is what that means. Optimal for what? Nasal breathing. So I redefine orthotropics, and I'm not an orthotropist. But I follow principles that optimize nasal breathing at the youngest age. So those are my influences. Those just came to me. I didn't even think of that.
That is so, and golly, John Mew. I mean, he's still going. He was lecturing recently in the States.
94, 95. Yeah, I just heard him recently.
Yeah. I just, it's interesting though. I mean, there's the, did you see the Netflix show that came out?
Yeah. Open Wide.
Open Wide.
Yeah.
So, I mean, everyone that I have on here that is, on this journey together, we have talked about the unfortunate arrows kind of flying around right now. And just some of the most brilliant people, just the resistance to acknowledging the connection between what you have coined, which I love, the craniofacial respiratory complex. I think you coined that, didn't you? I always give you credit for it.
I developed it with Stephen Sheldon,
head
of sleep medicine, and he was very much interested in non-surgical. What we, with Reza Moahed, I was with last week, and I just said, we're going to develop a talk together, MMA surgery, right? How about non-surgical MMA? And that's what we're doing.
That's exactly right.
He totally agrees with it. It took a while.
It did, because we both know Reza. And I've been saying that to Reza too, but I think he's understanding, like, there's definitely, once you're not growing anymore, and you can do a lot of things with skeletal expansion, you can, but sometimes we need surgical interventions, right? We just have to. They're not growing any longer. And we have to address the anatomy. But man, if we can get to these kids when they're malleable, and it makes such an impact, and you're virtually doing non-surgical MMA, you're getting the face forward.
It isn't just their soft and hard tissues that are malleable. It is their brains and their emotions. And you may have heard, but this is a new thesis that I'm developing. And there's two things. Children are hardwired to want to imitate adult culture. And this comes from the anthropology work that I've been doing. And it's more the cultural anthropologists that have known this for decades, that kids are hardwired to assimilate adult culture. They like to imitate. They like to please the elders of the tribe, the parents, the allo parents, co-parenting, other parents, moms who couldn't nurse, another lactating woman would nurse other kids. And that's how our hunter-gatherer history is. Well, now that if you know that, and it's true, by the way, it's a hypothesis, but so is the law of gravity. That's a hypothesis. It's very well supported. Okay.
Right, right.
If when people understand that these children, if they have what used to be called distal occlusion, what we call a class two, it appears in like 1, 2, 3 years old, maybe in utero. We're exploring a hypothesis. Ask Courtney Levin about that sometime. She and I, before she finished her residency, spent a lot of time talking about, I wonder, if we can see it on an ultrasound. And her program director left and we couldn't explore it anymore, but we're picking it up again. It's becoming a big deal. Anyway, the whole thing about, well, why is how is it that Peter Vig, it just, wants to put John Mew into the ground and his colleague? Peter Vig is an orthodontic academic legend, okay? But he says over and over again, and I first heard him say it on that open wide, there is no known disease associated with malocclusion, none. And I can't play that ortho mythology. Okay. Do you know why what I think the biggest barrier is to people? We've known for 100 years that
Yes,
distal step molar will never not turn into a class two
that's
skeletal.
right.
Okay. Do you know why the orthodontic community is, well, even though we know that there's no known disease and we'll treat them older because they're scared. They do not have behavior guidance training in their residencies. It implies you won't be treating them. And actually, Milt Gavelis, who learned, from Zaghi, the technique for resection of tongue.
Yes,
He says, Kevin, there are orthodontists, and I won't tell you their names unless you really want them, that call you unethical for expanding 3 and 4-year-olds that have maxillary transverse deficiency without a crossbite. Well, if you upright the lingual verted posterior occlusion,
that's right.
you're gonna get your damn crossbite.
You'll get your crossbite. It's the teeth compensate. Those little white things are coming in, they're bullied around, and they just compensate and come in, if they have to come in at an angle, if they have to come in, a little more lingual verted, that's what they're going to do. But the bone is deficient. And this is, I always say in my lectures when I'm talking to people, just about the importance, like, why are we screening? Why are we identifying? Why is it important to intercept early? I always reference what you said. It was one of the first lectures you ever said, or that I ever sat on with you. And um, you said, why would we? Because what some of them get concerned about is, well, they're going to need expansion again, and they might need expansion again. It's like, well, what about a child that can't see? They're going to need a little glasses, and then they're going to probably need a bigger set of glasses, and they're probably going to need a bigger set of glasses. You don't deny that child the important uh, neurosensory input, right? That they're supposed to have to develop to be their optimal selves. If you see a hiccup in the trajectory of a child's development, you insert yourself. Why is craniofacial development any different? It's because what you just said, I really do think it's a few things. One, they have to change their model. And that is scary for people to change a paradigm shift and to change a model that's working in their practice financially for them. So I think there's a little bit of well, this is just how the practice works. But I also think it's fear. There's a lot of fear behind this.
There's lots of fear. And that's so rewarding to me to hear you reiterate that about the ophthalmology. A developmental ophthalmologist would never say to the parents of a 4-year-old with nearsightedness, oh, wait till he's older, wait till he's maybe almost blind and irreversible. Myopia, nearsightedness cannot self-correct. It actually always gets worse. You can only slow down the progress of it. Whereas what we do, if we get in early enough, we can reverse it and we can guide it. So that's where the analogy kind of falls off. But I want to get back, please, to the fear thing, in the lack of training in child development, behavior guidance. And really what I say is, ASAP, you are the platform. I also work with Airway Health Solutions.
Yes.
I want to be on every platform there is. I don't want to. Oh no, I only do this. And I so appreciate, and Lauren Gates, she said knew I was going to be on ASAP, and she just thought that was great that we get out there. And really, Bill Hang's got something. I think we should
Yes.
all be encouraging each other, especially in this early childhood malocclusion before 72 months old. The behavior guidance thing, there needs to be continuing education courses in it, but all the courses should do, and I suggest ASAP, you guys, and I would help you develop this if you wanted me to, is that all you have to do is unlock what's already in there with people. If you're a parent, you know behavior guidance. And
That's so true. Yes.
well, most residents in pedo and ortho were either not married, or married without kids, or married with young kids. The only parenting we know is what we learned. It may have been good parenting or bad parenting. So it's just something that I really think needs to be inserted officially into the Committee on Dental Accreditation, CODA. It needs to get into the curriculum. Not pedo. Pedo's got it. We're the only ones who get it in healthcare. Maybe some ophthalmologists get it too. I don't know. I'm curious about this. But this is what's got to change, or this will never happen. We're going to be the only ones doing it. And we've got to get and tell people you can start at 2, 3, 4, and 5. Class 2 distal step, distal occlusion always is accompanied by maxillomandibular transverse deficiency. Always,
Yes.
always.
It's always narrow.
And
It's
they're
always a narrow
narrow.
arch.
In vertical growth, you cannot see it without an x-ray in a kid under 6 years old. Vertical growth, long face syndrome, adenoid face, you need an x-ray to pick that up in a toddler. Okay, sorry. And everyone says, no, you shouldn't take x-rays. 7 microsieverts is what?
Exactly.
7
It's the
microsieverts.
so low,
It's
slow.
not low.
Yes, very low.
So thanks for giving me the opportunity to. I'm just so frustrated about this.
I know. Well, we all echo that with you, Kevin. And I think, uh, I think that's a brilliant idea, which I believe we actually have you speaking in ASAP coming up, in a webinar. Literally, like a lot of our members, when I mentioned something about, you mentioned the behavior management aspect, and then man, the members were like, we have to know more about this. We have to know more about this. And like you said, it takes all of us together. My hat goes off to Airway Health Solutions and all the other platforms, because it is going to take all of us together to raise awareness, and a rising tide raises all ships. So,
You've already got in your faculty, Audrey Yoon. I mean,
oh
do it
gosh, yeah.
ortho, but get her to talk about how she gets 3 and 4-year-olds to open their mouth.
And that is what people say when I
Ah,
lecture there. I'll say I mean, I've got little 3 and 4 year olds in little Invisalign first, and people will say, and it's inevitably, it's really, really interesting too. A lot of it, I've had a lot of pediatric dentists sometimes say to me, how can you do that on somebody so young? Like there's no way they're going to sit in the chair for that. I'm like, I'll take a 4-year-old in Invisalign or an expander over a 9-year-old any day. or
if you go back to the kids that you're having great success with in terms of cooperation, Stacy, look in the mirror and compliment yourself, because you have enriched that parent. That parent has learned from you, and that is conveyed to the child that this mommy and daddy are so proud of you. Not that we're disappointed that you won't wear it. We're happy when you do wear it. And if a 3-year-old gets an expander and it takes them 6 months to get used to it, so what? No orthodontist wants to be in the same zip code with that kid till he's 10. So
exactly, it's a demographic that's being ignored. So it's somebody's got to do something. And we even we'll do a little, like, we'll get up and down the hall and clap for them as they walk down the hall and just tell them how proud we are of them. I mean, these kids are amazing. And they do want to please.
they do.
And they do. And I think that when you understand that, the psychology and the behavior management and the impact you can have on these kids. The other thing too is I talked to Mike DeLuke about this one time. I had a little girl. I mean, we hadn't expanded her yet, but all I did at this point was refer her to the ENT. At this point, I mean, she was basically suffocating. And yes, you could see all the malocclusion as a result. But Dad and I were talking about her, over her. She was in my chair just for a dental checkup. So I was following up with Dad. Ever since the tonsils and adenoids were removed, how is sleep? How are things going for her? And Dad was just going on and on. He's like, oh my gosh, I know we got to do the orthodontics next, but I'm so glad we addressed it. I mean, her life has just changed. Our lives have changed. And as Dad and I are talking about her over her, so we're speaking about her over her, and she's listening,
Of course.
she starts grabbing my arm, rubbing her face against my arm. And then, like, within minutes, she's pulled my whole body down, like on top of her, and she's just hugging me. And it's like, she said, the only thing she said was, my doctor, my doctor.
Mm.
And all I could get from that was gratefulness that she felt I loved her. I loved her. And she felt that I and her
Mommy and
dad
Daddy,
loved her.
and Daddy love you too. And that is all the endorsement. She picked up on that. And I know what you're talking about. That's perfect evidence for my hypothesis, is that they really are hardwired to please. I just I can't emphasize that enough. The other thing, if I could, Stacy, I listen intently. Sometimes the conversations that are going on ASAP and I'm driving and I just listen to all the comments. There's one thing I've learned, and I would like other people to consider this. Please, at least get the upper expansion done. The upper jaw, as Ben Moralia says, is the criminal, the lower jaw is the victim. And even though that child will inevitably need a lower expansion, don't put two appliances in a 3, 4, or 5-year-old. Just don't do that. It's cruel and unusual punishment. Put the top one in. The lower will come with the top. That's evidence-based going back 100 years, is that the curve of Wilson, the posterior on the lower will upright. Lower crowding, lower nose space is a proxy predictor that there's maxillary transverse deficiency.
Yes, yes.
But let it go just with one. And when the sixes are starting to erupt, add the bottom one. Tell the parents there will be a lower expander coming. Just be curious about it. Tell me I'm wrong. Give me evidence that no, we put both in. There's a rare case every once in a while where I'll put a lower one in before those sixes are close to erupting. There's no suture here, okay? And a lot of
Right.
people think you can't expand the mandible. Well, you're right. You can't suturely expand the mandible because there's no suture, right?
100%.
But you can develop it.
Upright. Yes, you
Right
can
there. So,
develop it properly. Dental alveolar
so is the upper.
expansion. Yeah, exactly.
Get it,
And
get
I
it.
mean, I think a lot of times too, um, people will say, you know, I think it's important to understand the diagnosis, like you and I keep talking about over the years. People want to know, what's the magic plastic that you put in there? There is
Yeah,
no
which
magic.
expander do you use?
Yeah, which expander
I
do you
only
use?
use one.
Yeah, I mean, it's really, it's what's the diagnosis and what are you trying to accomplish? That's what matters. And you can do that with multiple devices and different styles. And it's just understanding what you're trying to change for that child, what are the goals, and being very specific with parents, what the goals of treatment are. Get in, get out, take a break. Sometimes we got to come back and revisit, like you said, maybe put in a lower. Some people even do lower, they might do lower clear aligners, while they're doing upper expander, just so it doesn't feel so cumbersome. Um,
God, boy, that's a great idea. I never that would be one approach to, because I just don't like having all that equipment in their mouth.
agreed, agreed. And it's a lot, and just let them get used to one thing, and Yeah, I always start with the upper two if I'm going to do an expander and let them get used to that. But a lot of people are like, you know what, while I'm doing that, I'm going to maybe do a lower clear aligner therapy and start doing that remodeling on the bottom in a less invasive way because I'm not looking for crazy skeletal changes. I mean, you'll get some skeletal changes, but it's more uprighting. Like it's the victim. So there's
Well, I
just
don't
different
think
ways to do
everybody,
it.
I don't think everybody needs to treat 2, 3, 4, and 5-year-olds, even though we know
Hmm.
unequivocally when you detect malocclusion, lack of tongue space at 2, 3, and 4, it will never self-correct. It will
Right.
always get worse. And it usually already is or will become comorbid. Don't say a risk factor, say comorbid with sleep and
Hmm.
breathing problems. And but you need to assess risk. You need to tell parents, look, the kid's only 3. I know this isn't going to get better. I'm really not yet comfortable, but learning about this. But I know so and so down the street does it. Maybe, we need to learn to. Everybody needs to assess risk.
Yes.
That's the ADA. It's a mandate. Can you call it that?
I
But
know it's like the guideline. It's the ADA has challenged us to include this. Like, look, if you're going to do oral cancer screenings, I mean, when I tell people that the American Dental Association, which, holy cow, what you and Steve Carstensen, that whole movement with the American Dental Association, I mean,
well, you too. You're on the faculty. You're part of it.
well, I mean, because of you guys. So thank you for that. Um, you the awareness that's being raised, I really think the next 5 years are going to be so interesting. Um, Hopefully we start seeing some changes and we are seeing changes. We
We
are
are.
seeing changes. I'm just hoping we start to see this discussed more in the academic realm. So you have a new dental student hearing about this. You have a new orthodontic resident, a new pediatric dentist. Holy cow, the pediatric dentists. Kevin, what are your thoughts on that? Like,
Well, the curriculum. It's the curriculum again. We follow what the orthodontists want, what they want us to do. And program directors are faced with, we've got to get these many requirements to give them a certificate. And then every 4 or 5 years, CODA is going to come in. Are you doing this? Are you doing that? And guess what the orthodontists tell us? If there's a crossbite and on Deluc, uh, Mike, it's Mike Deluc, right? Is that it?
yes, yeah, yeah,
And I encourage everyone on his podcast this morning, and I'm only a half hour into it. He didn't get to behavior. Derek Mahoney and him were talking, but he called out Audrey Yoon of what she's doing at the University of Pacific. It's the only ortho program on the planet
yes,
because of her, that this is getting. So when the curriculum changes, and let me tell you about a CODA curriculum, because I was a program director for a while. Oh God, I never want to do that again. I went back to private practice, but I had to study the CODA curriculum for pedo, and sleep was starting to come into, oh my God, I have to do this. And I was in California. I was at Rady Children's Hospital. It was part of UCLA. But I was coming back to Chicago, and I was still at Lurie Children's. And I just saw this, boy, you can change, you can do things within the curriculum. Biomedical sciences, it fits under that. So you can put sleep in there. There's ways to do it, but most program directors, I don't know, did you study old tests in dental school because they use the same tests over and over again? And
yes,
that's what we did at Loyola. Well, program directors are no different. We keep repeating the curriculum because
yes,
they pass CODA every year. No, when program directors have the courage, like Audrey, and she's not a program director, but she's impacted that curriculum, that's what's got to change. And then we're going to start to, sealants. Sealants was never part of the curriculum. That took forever to get into the curriculum. So that's all. I won't preach, but
yeah, no, but you're right. I mean, what she is doing by incorporating sleep education within the orthodontic residency, they come out understanding sleep health, and that's something that you and I had to put the work in post graduation and start really learning that on our own. And, I just, for any dentist, orthodontist, or general dentist, primary care dentist listening right now, just the fact that you're listening and that sets you apart. And I'm just super proud of the people that are saying, you know what, there is something to this. I'm gonna listen. I'm gonna start looking at my patients different. And I think that just has a ripple effect on our communities and um on humans, on our generation. I think this is an amazing time to be a practitioner. I think we're going to see the collaboration between medicine and dentistry just really change in the next 5 to 10 years.
I think you may have heard of the Endeavor Group, which is
Yes.
like a little think tank that Lauren Ballinger and Steve Carstensen and I had started, and then we incorporated, and there's like 12 or 13 people from all disciplines of oral health. And the two main pillars of it was what we need to do is decrease the need and demand for restorative services in the under six population and raise public awareness and demand for airway health related services. And that, we were going nuts in the pandemic because we couldn't be with our tribe. We couldn't be helping these kids. It was cathartic for us. Well, now the ADA is paying attention to some of those pillars, and AAPMD has sort of incorporated us. So we're still active, but we're not on our own. I think that's what really needs to happen is decrease need and demand for what I call, dietoinfectious disease. It's stripped fiber from carbohydrate. Cavities didn't enter into the human condition until we discovered how to separate fiber
Fiber.
and sugar, and create fermentable carbohydrates. 10,000 years ago, first cavities. We go back 300,000 years. I won't belabor my anthropology background, but that's stunning to me. That really relatively no tooth decay till about a minute ago in terms of how long we've been on the planet. So I really think that's starting to, people are becoming curious about it. I don't know. I just in the actual, when we talk about nutrition, you know what nutrition means to diet? Like I taught in a dietetics program as a grad student, and nutrition means nutrients, biochemistry. No, nutrition is acquisition of nutrients. How do you get it from the environment? Process it biologically.
Mm.
Chewing, hello, firm food, not overly processed commercially. And those are the things. I'm speaking in Las Vegas on Saturday at this IOMT, that's
Oh,
toxicology.
yeah.
Yeah. And you've heard of Weston Price's book, Nutrition
Yes.
and Physical Degeneration. My title is Nutrition and Physical Regeneration. And I'm going to be talking about chewing and the masticatory hypothesis for why everybody had big forward jaws if you survived childhood. If you didn't have things that were conducive to that, you didn't survive childhood. And no
Yeah.
kid ever lived long enough to develop a malocclusion. That's why we see no malocclusion at any age until about 400 or 500 years ago, because you wouldn't survive long enough to develop malocclusion. People who died with perfect jaws. It's incredible. How's that for a hypothesis?
Exactly. Yes. And
We
it,
can
and
live
you
with anything now.
it's so interesting too. Like, I mean, the jaws, they're connected to, I always say, like, there's an airway above the maxilla and behind the maxilla and the mandible. I mean, to say that there is zero influence and relationship when one is not healthy, I mean, it's really kind of silly. I mean, and when I talk to parents and I show them a cone beam and I take them on the journey of their child's growth and development on with a cone beam, and Mike said the same thing, Mike DeLuke, it's like, it's common sense. Let's not throw out our logic and common sense.
Another thing I think is ludicrous is when we say, well, oral health as a component of overall health. That's a word that starts with bull, as an S in the middle, and it's not bullseye. Okay.
Right.
Is that you would never hear a cardiologist say, well, cardiac health is a component of whole health. Are you kidding? If your heart's not healthy, you're not healthy. If your oral health now, airway, because of Steve Carstensen and people like, you and Michelle and Tracy, that These things are now that airway hygiene means health. It doesn't mean clean. Cleanliness is a component of hygiene, but airway health is now considered on the same continuum with plaque mediated disease, trauma, syndromes, things like that. But airway health is a component of what anything above the neck is a shared domain. When people say, oh, the airway, that's the domain of the ENT. Yes, there's two. It's our domain. We share this
We
domain.
share it. Yes.
They know it, but they need us. We need them.
Yes. It's so
And I know
true.
you know this, but that's what you're doing, what you guys are doing. I am just and before we have to go, because I know you have to get going at some point soon. Um, Stacy, what the way you interview, it's like somebody being a good listener. You are a good vocaler. I mean, it only comes from intense, caring, compassionate listening that you
Yeah.
are able to extract things out of people. No, your podcasts are. I could not wait to do this with you because I knew you were going to get stuff out of me that maybe I'm starting to have new ideas now. And this talk I'm giving in Las Vegas, I'm rearranging some slides just based on things we're talking about. Um, you're very good at this. And I encourage you to get more people on about behavior guidance. Patrick Turley, Pat Turley and his wife at UCLA, orthodontist, pedodontist, they're the only textbook in an ortho textbook that talks about the importance of behavior guidance. Stacy Quo, who knows Audrey from Gimeno, she knows a lot about pediatric behavior guidance. She's somebody, so get some of these
I
people.
got to get these people. Yeah. When we're done with this, I got to get those names from you so we can have further conversation. And I want to thank you for the kind words you just spoke about me because that means a lot. It means a lot to me, Kevin. Very,
Well,
very, very
it's
much.
important that we point out each other's, not just our weaknesses. We're all good at that, right?
Yes. Isn't
but
that the
but
truth?
their fortes, these things that you're good at. And boy, you never know when you're telling a little kid, you are like, you're listening so well, we're so proud of you. You don't know that seed that you're planting in
Mm,
their child, where they're going to go with that, to be edified. And adults need it too.
yeah,
I
we all need it. We
we're-
all need it as just as human beings. And the impact, we were talking before I hit record, just the impact of being present, being in the moment. We're hopping around from chair to chair to chair, or, busy parents, you're just go, 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 go. And, I catch myself sometimes, already future pacing, thinking about what I got to do next. And it's like I have to be mindful, whether it's as a practitioner, as a mother, as a friend, as a sister, as a daughter, you know, be in the moment. It matters. Be in the
and
moment. And
don't be less intense. Increase your intensity. And I say that to you, but of all your ASAP followers, continue being intense and become more intense.
ooh, I
Uh,
like that.
so we don't have a lot of time left. None of us do. Nobody gets out of here alive, we were saying,
So
right?
one-way ticket. No one's getting out of here alive. So, you definitely have been very intense with your mission and your purpose here and why you are here for such a time as this. You were supposed to be here spreading this um, awareness, this movement, creating your mentorship, creating other mentors for others. I mean, you're like the mega mentor in all of this, Kevin. And that's why I want to know who's yours. I mean, the ripple effect that we have, it's amazing. It's amazing. I'm so glad you came today. And I'm going to have you back because I think what I would love to talk about again is maybe we could dive in deeper to the behavior management.
Mhm.
You know what I mean? Like maybe we could have some further conversations about some examples of things that you're doing and I'm doing that overcome our fears.
I think even here, like what you said, Well, it's cognitive dissonance. When you hold two apparently opposing ideas in your brain, but you can still function. That's what's going on. And we're criticizing orthodontists, but it could be us. How come more ASAP people are not treating 2.5, 3-year-olds? Because admit it, I'm scared. It's okay.
It's okay.
Overcome the fear because you know their malocclusion will not improve. It won't self-correct.
No,
Never, never.
never.
And there's literature to support it. Well, you're a parent, you were parented. Just don't be fearful. Just and start out with somebody that you can make mistakes on and that will understand. One of your staff, one of your neighbors, relatives, whatever. It will do good. This was being done 100 years ago.
Yes, I was just going to
30,
say it.
30 months of age, the ideal time to treat. Sam Cohen, 1922, JAMA. Edward Augustus Bogue, MD, DDS, Dr. Bogue. He's my hero. Oh,
1918 was that was that paper.
yeah. And he said he he spread a deciduous arch for the purpose of gaining nasal respiratory advantage, not to correct irregularities of teeth, 7 years after the last shot was fired in the Civil War. Okay. So go figure. This is nothing new under the sun. Well, rock and roll. This has just been so wonderful, Stacy.
Well, same here, friend. I have my questions for you. I got to ask you my questions. Who's your favorite music artist?
The Beatles. I mean, it took me a while. The Beatles. Oh my gosh.
Well, I mean, you are a little John Lennon-esque.
Now, his idol was a Roman philosopher named Lucretius. Look up Lucretius.
Lucretius.
Oh yeah, it is like it is. He wrote one book. Lucretius did that survived, and on the nature of things is in English. But
Okay.
that impacted General Patton in World War II. There's all kinds of visionaries who Lucretius,
Inspired.
amazing. Yeah. So
Well,
yeah,
that
that's it.
doesn't shock me that it's the Beatles because I mean, yes, if anybody hasn't seen Kevin, he's got a little John Lennon-esque to him. What was your favorite activity as a kid? We talked earlier about your childhood. You just had such a great childhood. And what was one of your favorite activities that just brings like great
I
memories?
I just right away, it was going to my Aunt Nan's cottage. She lived, her husband died in a car accident. She invested in Wrigley chewing gum with the money she got from the insurance and became almost a millionaire because it kept splitting and she kept reinvesting it. She bought a cottage on Lake Michigan in Holland, Michigan. And my parents were going through a divorce, and I would spend 3 idyllic summers up there and I was king. And she just, her kid had grown up and Robbie, my cut. And I don't know, that was my favorite activity.
But it was so impactful. Three
Yeah,
summers there, huh?
3 summers and they were idyllic. They just like, and we vacation. I'm raising my kid. They're adults now, but we went right near Aunt Nan's cottage ever since they were born. We started going up there in Holland, Michigan.
Mm, that is
I guess
awesome.
that's it. Yeah.
Yeah, that is awesome. And it shows you too the impact. Here you are reminiscing about those summers. So, what happens when we're little really, really matters. What
Really,
it really does. Are you a chocolate or vanilla guy?
I'm chocolate, milk chocolate, not healthy chocolate. I like
Not the healthy dark
I
chocolate.
like garbage chocolate, Belgian chocolate. Oh, I love chocolate.
I do too.
But
It's
malted, I like vanilla malted. I never get a chocolate malted. So there you go.
That's so funny. I'm a vanilla malt. Okay.
Yeah,
And the kids are like, I know I sound old, but if I'm going to get something vanilla, I go to Culver's because they'll put malt in it for me. And they're
yeah.
like, what
Most
is
people don't know
malt?
what a malted
They
is.
don't know what malt it
The
is. It's the
milkshake,
best.
and I always ask for extra malt powder. Oh,
Yes. Me too, Kevin. Maybe that's why we're
all
such
right.
good friends.
I like it in your comments.
It's my favorite, the malted vanilla.
That's great.
Well, Kevin, I love you. And
Love you too.
I appreciate you being on here, and we'll do this again, friend. Talk to you soon.
Okay. All right. Have a great day.
You too. Bye, everybody.